Cancer causes so much suffering for so many people, as we know. You either know someone who's had it, or maybe you've had it yourself. Patients and their loved ones deserve, though, to know that cancer care is getting better. Good morning. I'm Jessica Lovell, and welcome to the Morning Medical Update. Today, we are highlighting some of the good news around cancer screenings and treatments. We'll hear from experts dedicated to easing the burden that cancer creates and get the best medical advice for catching it and preventing it. But first, let's get to our morning rounds. With Earth Day tomorrow, we want to highlight the health system's effort to keep medical devices out of landfills. There are thousands of different devices that are used only once, then thrown away when they don't have to be. Chris Heath is the System Director for Clinical Supply Optimization at the University of Kansas Health System, and we're so glad you're with us today. The health system has been recognized for its work in 2022. We kept more than 6,900 pounds of devices out of the trash. Chris, how did we do it?
Sure. We had a very successful 2022, and we did that by expanding our product portfolio for reprocessed products, concentrating on collections, and creating strong partnerships with our physicians and clinical end users. What really sets our program apart is we have a team of dedicated individuals within CSO that concentrate, foster those relationships, help to expand the program, and help to communicate and educate while bringing data-driven opportunities to the table.
Yeah, it's like a big team effort, those relationships, as you mentioned. So we talked to staff up on the pre-operation unit where they see about 80 patients every single day. Every single patient has compression sleeves, pulse oximeters. One healthcare tech says she feels really good knowing that those devices aren't just a single use.
I think it's really important to reduce our carbon footprint because we see so many people. I think we kind of have a responsibility to do our best to reduce what we use.
So Chris, what have you heard from staff about the reprocessing efforts that we have going on here?
Everybody really seems to be on board. Green initiatives and environmental sustainability seems to be at the top of everyone's priority list. The success of this program really shows that we as a health system not only care about our patients, but we care about our community and its future as well.
Yeah, going green, being green feels really, really good. We also heard from an employee in charge of ordering and stocking these devices. Billy Martin works in the electrophysiology lab where they use special catheters to reach inside your body. He says reprocessing makes financial sense too.
A lot of these items are higher dollar items. I mean, range from $1,000 to $4,000 a piece. So when we go to Medline, it's actually a fraction of the price.
So Chris, we're getting these devices back. How does that work?
So we do purchase back some of these devices, especially things like SCD sleeves and air transfer mats. We collect about 3,000 devices per month throughout the health system, and actually saved the health system about $1.2 million last year by purchasing reprocessed products. On top of that, everyone has felt a pinch of supply chain in the last couple of years due to COVID and supply shortages. So being able to purchase reprocessed products when the original is not available has also been an advantage for us.
And certainly, as you mentioned earlier, this whole process only works if staff are on board, right?
That is absolutely correct. We would not see any success with the program without our dedicated staff. So whether you're an individual putting products into our blue bins, whether you're a supply chain staff member stocking and ordering product, or a physician who's utilizing reprocessed products, we all contribute to the program and its green initiatives, and would not see success without everybody pitching in.
That's right. Chris, thank you for the work that you and your teams do. You make the whole health system world go round, all that behind the scenes. So thank you very much. So cancer awareness is one thing, but April is Cancer Control Month, and we have 4 experts here ready to break down what cancer control really means as far as a big picture. Here in studio with us is Christy Beffert, Dr. Christy Beffert, the Associate Director of Cancer Prevention and Control at the University of Kansas Cancer Center. How are you?
Good morning.
Good to see you. And Dr. AJ Bansal, a gastroenterologist, a GI doc, also with KU Cancer Center joining us. Good to see you, Dr. Bansal.
Likewise, thank you.
We also are joined remotely by Dr. Simon Lee. He is chair of the Department of Population Health at the University of Kansas Medical Center. And Dr. Lauren Nye is breast oncologist, also at KU Cancer Center. Good morning to you both.
Good morning.
Good morning.
Good to see you. So when we talk about cancer control, Some experts use cancer continuum, that term. We're also seeing that there are 6 steps from etiology to survivorship. Dr. Bedford, let's start with you. Not everybody knows what etiology is, what it means. Help us break that term down and why it's so important.
So etiology simply means what is the origin of cancer development or what causes it. And it can be a whole variety of things, from the environment to things you consume to infectious diseases, how those things interact with your genetics. And so scientists, epidemiologists study exposure to these things and follow groups of folks long term to see which ones are predictive or cause risk for developing cancer. So it's the very first step in the whole cancer control
And when you talk
continuum.
about difference between cancer prevention, cancer control is the big umbrella in which prevention falls under.
Correct,
And
yes.
these different 6 silos that we're going to talk about this morning. Dr. Lee, how far have we come in understanding the genetic side of cancer?
When most of us think about genetics, we're usually thinking about, family hair color, right? Those are the genes we inherit from our parents that code for family traits. Some abnormal changes in those genes can be passed down and may increase your risk for certain kinds of cancer. Perhaps the most famous is BRCA1 and 2, which is commonly recognized as increasing risk for breast cancer, and that's why we test among first-degree relatives. But cancer cells themselves can also have mutations. These are not inheritable between family generations, but my colleagues in lab and clinical science have discovered that the genetics at the level of the tumor cell drive how the cancer cell grows or progresses. And so biomarker testing checks a sample of the tumor, or sometimes blood, and I think Dr. Bansal might want to talk about that, from a patient with cancer. Oncologists then target their treatments to the details of that specific cancer, so you have better treatment outcomes like slowing tumor growth or improving quality of life. And it also helps to avoid the use of ineffective treatments, and ultimately then you're going to lower your treatment costs.
Dr. Bansal?
So thank you, Dr. Lee, for setting this up so nicely. So in fact, blood-based cancer testing is a new area of research. As you all know, PSA has been used widely for prostate cancer, and obviously there's still some controversy about using it broadly in all patients, but definitely it makes a difference in the right population, and the key is the right population for these tests. So what these blood-based tests will be doing is that they'll be measuring mutations which are happening in an organ in the blood, just something which we call a liquid biopsy. And by doing that, we can diagnose many of the cancers at an early stage. As you all know, we have well-established prevention programs for breast cancer, mammography, for colon cancer. We have stool-based testing and colonoscopy. But for many of other cancers like pancreas or brain and other cancers, we do not have established screening methods, and that's one of the places where blood-based testing will make a huge difference as we know more and more about this.
And Dr. Nye, I want to ask you the same question. What are you seeing as far as breast cancer in that type of research and clinically speaking?
In terms of using the blood-based tests for breast cancer early detection, for right now, we haven't seen that come into the mainstream, but we definitely use germline genetic testing to identify if somebody is at an increased risk for breast cancer, and that may guide some more intense screening recommendations or even risk reduction recommendations. In the cancer treatment phase, we're still exploring the use of some of the blood-based test options for early detection of recurrence.
So hopefully a lot of exciting news on the horizon. The second step, though, in the continuum is prevention, as we've mentioned. Some of the best ways to prevent cancer should be obvious by now: not using tobacco, limiting alcohol, wearing sunscreen, watching your diet. Dr. Bansal, how does a healthy diet impact cancer risk?
Thank you, Jessica, for that great question. So obviously that's a question which all of us get in our practice of medicine from our patients, because clearly there's a clear link between diet and cancer when you look at studies, but what exactly we should be doing. So there was a very large study done on the West Coast in which they looked at patients' diet in great detail and then measured a bunch of antioxidants and other nutrients in the blood which can decrease the risk of cancer. And what they found was that people who have at least 3 to 5 servings of fruits and vegetables per day had a much lower risk of cancer. And also when they, for simplicity, to give you advice and something which is practical to even tell a 6-year-old and a 12-year-old to practice is, when you sit down to eat, make sure you have 4 different colors on the plate, some broccoli, some meat, some potatoes. So when you have 4 different colors on the plate, that means that you have a nice variety of nutrients to prevent cancer in the long run.
So Dr. Nye, how does someone know if they're at high risk of breast cancer? What can they truly do day to day to reduce that risk?
Great question. So the most common reason somebody is at an increased risk of breast cancer is their family history. So unfortunately, breast cancer is really common. 1 in 8 women will be diagnosed with breast cancer, but some women may have an even higher risk if they have what we call a first-degree relative with breast cancer, a mom or a sister with breast cancer, or multiple relatives with breast cancer, aunts, and it can come from either side of the family. A lot of people think it only contributes from mom's side, but it can come from your father's side as well, that family history impacting risk. But there's many other ways your risk can be elevated. Some women get exposed to radiation at a young age for the treatment of certain cancers like lymphoma. Other women have abnormal breast biopsies that show atypia or predisposing lesions that tell us there's busy breast tissue and they're at an increased risk of breast cancer. And then we also do genetic testing, like we talked about, to identify women who have something in their DNA that tells us that they're at an increased risk of breast cancer. Once those women are identified, they can have more intense screening for early detection, and that can be beyond the 3D mammogram. It can include breast MRI or contrast-enhanced mammography, as well as options for risk reduction, which we mostly focus on those lifestyle factors. We talk about filling your plate with good fruits and vegetables, as well as exercise and limiting alcohol. But we also have drugs, what we call chemo prevention, or medications that can be used to lower the risk of breast cancer. And not many women are aware of those options, but they can reduce the risk of breast cancer by 50%.
So the third step in the continuum is detection. Screenings are so important: mammograms, colonoscopy, pap smears, all sorts of ways that we can try to get ahead of this. Dr. Bansal, we talk about colonoscopies on this program. We talk about the PrEP, not pleasant, but just how important are those screenings and people making sure that they are getting those on the calendar and not missing those dates?
Absolutely, that's a very, very important point. So clearly, all of these tablet screening programs have been shown to make a big difference, saving lives, decreasing the risk of cancer. So the PrEP is annoying, but I have to say, for people who have gone through the colonoscopy PrEP, I had my colonoscopy 5 months ago. It wasn't fun, but it wasn't too bad either. And we have come a long way. 10, 20 years ago, the amount of PrEP we used to give our patients was much, much larger. But believe it or not, it's much, much better, and the volume is almost half of what we used to use 20 years ago. So don't be afraid of the PrEP, because the alternative is having invasive cancer, and that's not a good situation.
The PrEP is annoying. Okay, I haven't heard it called annoying, but yes, that's a more pleasant way of saying it. Yes, and it's not as bad, and it's necessary.
And we have different flavors now. You know,
different flavors. There you go.
Yes.
Okay, that's the bright side of that PrEP. So I just want to talk about also mammograms, because the mammogram technology, Dr. Nye, has improved over the years. There's different levels of expertise in reading mammograms. Tell people why that really makes a difference.
Yes, so several years ago, we started only offering the 3D mammogram, and that's different from the 2D mammogram, which was the standard before. And the 3D mammogram increases cancer detection and also lowers the recall rate, meaning lowers the risk of the radiologist telling you you need to come back and do further imaging or testing. Here at KU, all of our breast imaging is read by dedicated breast radiologists. That means that they had additional training to read breast imaging, and that is all they do all day, every day, is read breast imaging. And so they're really experts in that field, and the quality of images that we can produce are really superior.
Dr. Befford, how do you drive that point home about the importance of screenings?
Yeah, so it's important to get screened, but it's also important to get screened on time. So a lot of times folks will feel pretty good when they get their mammogram done, and then it goes on the back burner and it stays on the back burner for too long. So even, delays 3 months, as low as 3 months can increase your risk of having a cancer that goes undetected early on. So getting it done, when you get those reminders in the mail or those phone calls, getting it scheduled and getting it done is really important.
It's no joke. Get it done. Yeah. There are reminders there for a reason. Okay, we're going to talk more about cancer treatment and survivorship here in just a moment. If you are watching right now, if you have questions, use the chat on YouTube and Facebook, tweet us, or email us at the Medical News Network. You can find info right there on your screen. Right now, let's get a quick check on our COVID count with Dr. Dana Hawkinson. Good morning.
Hi. Happy Friday. It's
No
nice
kidding.
Yeah.
No kidding.
So right now the active cases, we have been seeing a decrease. Luckily, we're still under 20. We have 25 total cases, but 13 active. Unfortunately, 3 in the ICU and 1 on the ventilator.
So Operation Warp Speed, we know the term, it helped create the COVID vaccine. Now the federal government is spending around $5 billion to speed up work on new COVID vaccines and treatments. They're calling it Project Next Gen.
Yeah.
So for comparison, Operation Warp Speed cost around $18 billion. And some people might be thinking, wait a minute, we already have these COVID vaccines. So why is this new development, why is this important though?
Yeah, this is so extremely important because what we have stated is that, it looks like COVID-19 is really starting to become a disease of the most at risk. That is those elderly patients, those patients with cancer that are on chemotherapy and are immunosuppressed. And so Project NextGen is very important to help develop even better vaccines, vaccines that have longer lasting, more durable immunity. They're looking at vaccines that have mucosal immunity. So that means immunity, say, in your nose and in that respiratory tract, so it can help block infection. In addition, Project NextGen is going to be coming up and starting to provide funds to develop new therapies such as monoclonal antibodies, because we know we had very effective monoclonal antibodies in the past, but with the new Omicron variants and sublineages, those monoclonal antibodies don't work anymore. So they are going to be looking at new therapies for that, but also pan-coronavirus vaccines is what they're going to be putting funding into. And what that means is that it is vaccines which help protect against all kinds of coronaviruses. Because if you remember, Jessica, SARS-CoV-1 infection, that was a coronavirus. MERS coronavirus infection, and now SARS-CoV-2. So we've had 3 very devastating diseases and disease processes over the last couple decades, all by coronaviruses. So I think this is really good. We certainly need funding. We have seen what happens when America and the country puts resources towards a project. We know we typically have very good results.
Thank you for that explanation. I remember when COVID first came out, you said, Jess, you think it's new, but me and my team's work, and we've heard of coronavirus for decades. So good to know. Let's talk cancer treatment. This is really important. Surgery, chemo, radiation, also immunotherapy, different targeted drugs that we know are out there. Dr. Beffert, what excites you most about the future of cancer treatment? And you are part of that future because you're doing research. Tell us a little bit about that too.
So, definitely the immunotherapy and the targeted therapy is very exciting because it gives patients treatment options who previously may not have had them. Just in the last 5 years, there's been so many exciting treatments come out. I think something that's especially exciting for those of us who focus on prevention is new ways to intercept cancer development as it has begun to, as cells have begun to display like atypia or abnormal things that would lead to cancer, and that's the use of vaccines. And I'm going to ask Dr. Bansal to describe a little bit about some of his exciting new work in this space.
Absolutely. So thank you, Christy. So the future of cancer prevention is immunoprevention. So we have learned by doing a lot of research that even medication like aspirin, which has been shown to prevent colon cancer in many instances, it still works by modulating the immune system, promoting those cells in circulation which prevent cancer, and suppressing those immune cells which promote cancer. So cancer vaccines are expected to shift the balance from equilibrium to elimination, which can eliminate precancer cells from the body to prevent future cancer. So we began a trial in patients with a syndrome called Lynch syndrome, where we are testing a combination of 3 different vaccines for prevention of not only colon cancer but other cancers in the body. And that trial is ongoing. We just got the vaccines last week. We'll be recruiting here at KU and 14 other hospitals in the country, East Coast, West Coast, Midwest, Puerto Rico. So stay tuned of how that goes.
Dr. Lee, what can you add about the work you and your teams are doing?
Well, this is why it's important to think about the cancer continuum as the big picture, but it often makes us think that it's linear, so that we only do prevention at the beginning as opposed to throughout the life course. And that's increasingly important to think about what we do for prevention for either second primaries or recurrence of a cancer. The last 20 years, we've seen, one of the most successful stories has been about these breakthroughs in vaccines. For HPV, for example, we now have multiple vaccines that target the types of HPV that cause cancer. There's bivalent, quadrivalent, even non-valent that address, 9 different subtypes of HPV. Those are the vaccines that prevent virus infections from successfully progressing to cancer. And they're now FDA approved for girls and boys from age 9 to 26, and also approved for some young adults through age 46 after they talk to their physician. But scientists are running trials that Dr. Bansal was talking about for different vaccines that can be used among patients who already have an HPV-related cancer, to trigger an immune system response where the patient's own body is going to kill those cancer cells, either slowing or stopping the growth of that cancer. That therapeutic vaccine is really different from prevention, so that we're actually addressing where a cancer has already started, and you can test them in combination with adjuvant treatments like the targeted genetic therapies that they discussed earlier. And if those trials demonstrate efficacy, then we'd be really closer to having FDA-approved vaccines that could actually cure an in situ cancer.
Let's talk about cancer survivorship. And I want to ask, first of all, Dr. Lee, I know that's an area in which you work and do research. Talk to us a little bit about that and what you're unearthing.
Sure. I think, one of the most important things that where the field of oncology has really led the world is thinking about multimodal treatment, right? So different modes of treatment that we've mentioned today, but more importantly, the different types of oncologists, the cancer doctors that work together as part of a multidisciplinary team. And that often involves palliative and other supportive care experts working to keep the focus on the needs of the patient after a diagnosis. That patient-centered care is also getting more precise through the cancer genetics targeted therapies that we've talked about, so that we have a specific treatment for the specific cancer in the right patient at the right time. What excites me is that coordination between oncology teams is also shaping how we involve other specialists, as well as strengthening the coordination with nurses and doctors in primary care, which is really important for cancer survivors as more and more people are living longer and better after their cancer treatment.
Dr. Nye, any challenges for breast cancer survivors, anything that they're facing as they continue on down the road, and what's also promising for them?
Absolutely. We've gotten much better at treating breast cancer and cancers in general. So we're seeing a greater number of survivors, but we're leaving them with toxicity. And so a lot of efforts are focused on minimizing toxicity, especially those long-term toxicities, such as peripheral neuropathy is a major one, as well as sexual health for many women, and just physical mobility and regaining their stamina after going through a diagnosis of breast cancer. And like Dr. Lee was mentioning, we have great multidisciplinary support, and we're very lucky for that. We have onco rehab physicians, we have a psychologist who specialize in the care of patients going through cancer, we have sexual health psychologists, we have a broad range of experts to help manage these toxicities. But a lot of therapies are starting to focus on minimizing those toxicities up front.
Same thing for GI patients?
Generally speaking, yeah, and I want to mention that many of the patients with GI cancers and many other cancers also receive chemotherapy, which can cause cognitive deficits, something called chemobrain, which can definitely affect people in the long run, relationships and jobs. And the second thing is many of the survivors worry about the second cancer, and that's very important to have a close relationship with your primary care and your oncologist or gastroenterologist or anybody else in the field to make sure that second cancer is prevented.
Any reporters with us today? Let's get to our community questions. And We have one from Yen. Is the technology of circulating tumor cells, CTC, becoming more popular in the U.S.? And is the cost high? Do you know anything about that?
Absolutely. So I can take that. That's a wonderful question. The technology has been around for a long, long time. So just to explain what these are, so these are tumor cells which break away from the primary source of cancer in any organ, and then they show up in the blood. Then you can use special technology to isolate them from the blood and look at them to see what is going on with the patient. So now we have gone a step further. So it's very hard to find enough number of CTCs or circulating tumor cells in the blood to get a meaningful diagnosis in many situations, so meaningful information. But now the focus is mainly on looking at the mutations in genes which can spill over into the blood from these cells, which is at a much higher density than circulating tumor cells, making it more practical and sensitive for predicting who has cancer and predicting recurrence.
And I'm going to throw this question out, and whoever wants to grab it, please do. Did the COVID pandemic change anything about overall cancer rates? What have we learned about it? What are we still learning about it?
Yeah, so one thing for sure is it impacted the likelihood of people coming in for screening. And I think we're still yet to see the impact of that on overall cancer incidence over the years. So it caused major delays in screening for both average risk and high risk people.
I want to get to today's takeaway. And Dr. Beffert, let's stay with you. What do you want folks to take away from our chat today?
That cancer control starts with understanding the risks and then doing what you can to prevent them. And there's many things. Most of cancer prevention happens with your individual choices, and it has to do with things like getting your screenings done, maintaining a healthy diet, exercising, having a healthy body weight, all of those things. So it takes the whole population to really accomplish national cancer control.
Dr. Nye, what's the takeaway today?
My takeaway is to make sure you're bringing up cancer risk with your primary care doctor, finding out what your risk is and what you should be doing for screening so you can stay on top of it, like we talked about earlier, and know that there are options to reduce that risk, so don't be afraid of it.
Dr. Lee?
I think that, thanks to the treatments that Dr. Nye and Dr. Bansal and colleagues are offering to patients with cancer, many cancer patients are ready to move on with their life after treatment. One of the most important things for cancer survivors to remember is that their other doctors need to know that they had a history of cancer, and they need to bring that up. Most of us, when we go to see a doctor, we have one thing that's on our mind. I have pain, and so I'm worried about that. I'm worried about my blood pressure. But it's really important for people who have a history of cancer, whether that's recently or a long time ago, to remember to tell their primary care doctor and make sure that that history of cancer is documented so that they're tracking what we need to do to make sure that we do surveillance going forward and we can manage all of your cancer risk appropriately as a survivor.
Great reminder. Dr. Lee, thank you so much. Dr. Bansal, what's the takeaway today?
Thank you, Jessica. Yeah, it's been a great session. So for me, I think there are two takeaways. First is don't be afraid of the PrEP, and it comes in many flavors.
Thank you.
And the second is think about your children. So a lot of healthy eating habits start when kids are young. So we have ample evidence to show that kids, their eating habits are set between the ages of 2 and 12, and those habits carry on forward. So make sure that when your kids get food on the dinner plate, they have 4 different colors on the plate.
Can you come over and help me do that?
Sure, I
Make
can.
them eat?
Happy to do it.
Okay, good.
I'm not the best cook, but I can definitely.
But you could do it. Okay, Dr. Bansal says so. Doctor's orders. Okay, Dr. Hawkinson, what's the takeaway on this Friday?
Yeah, Doritos is not on that, I would assume.
Right.
Now, I'd be remiss if I didn't continue to endorse what we've already heard from our guests here, so vitally important. Need to continue to endorse the screening and the prevention, just as we heard. Screening is vitally important, but also prevention, including and especially those vaccines. We know the HPV vaccine can protect you against cancer. If you are a candidate for it, please talk to your medical providers, but please get your children vaccinated against HPV.
Great chat today. Thanks to all of our guests and our viewers. We'll see you back here Monday at 8. Coming up Monday on the Morning Medical Update, religious beliefs posed a challenge for treating a young woman diagnosed with leukemia. Blood transfusions are not permitted for Jehovah's Witness followers. I'm Jessica Lovell. On the next Morning Medical Update, doctors at the University of Kansas Cancer Center accepted the challenge with a treatment option that met both her medical and spiritual needs. That's Monday at 8 a.m.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.